Adrian, thank you very much, and Radu for hosting this session. It's a pleasure to be here. I have to say that having been here twice before, I was very much looking forward to this visit. Everyone here is very hospitable, and it's a great pleasure to be here. Special thanks also to Gabriel for hosting us, and Madalena Illy, who did a lot of work to ensure my travels went well. So I was asked to address the newer endoscopic approach of sleeve gastroplasty for morbid obesity. First of all, a little bit of background. Unfortunately, I did not make the earlier session, so you may have had much of this information earlier in the day. But essentially, when we're dealing with obesity, we're talking about BMI greater than 30, with class 1 being 30 to 35, class 2 35 to 40, and then the severely or morbidly obese of BMI of 40 or greater. So if we look at the United States, where we have a lot of data that I've put together, the rate of obesity has increased over the last 5 decades from 13.4% to 36.4%. That translates to close to 100 million Americans with obesity, and obviously this can be extrapolated to the rest of the world, but I think perhaps the United States is the worst example of obesity. And if we look at the total cost of the healthcare budgets, we're talking about 15% of total healthcare budget being devoted to this single problem. Estimated cost, close to $1 trillion. So it's a huge, huge problem. If we look at the trends in bariatric surgery to deal with this, we can see that going from 2011 up to 2016, the blue bars on the bottom represent sleeve gastrectomy, and we can see that as a choice for bariatric surgery, I think you heard about this earlier, it now comprises about 58.7% of all surgical operations for obesity. Roux-en-Y gastric bypass has been diminishing in popularity, mainly because of morbidity, and then there's a very almost disappearance of the banded gastroplasty, as it's really not that effective. And then we have revisional surgery, and more recently in the last 5 years, the endoscopists have delved into the problem in a big way to try to come up with an easier solution. If we look at the number of surgeries in the United States, which is a little bit over 200,000, we're only dealing with 2% of the population. So 98% of the obese population are not being managed effectively, medically, pharmacologically, with lifestyle changes, etc. So it leaves a huge area for endoscopic intervention. So the range of interventions endoscopically include reducing the capacity of the stomach with space-occupying devices, and basically we're talking about balloons, air or water-filled balloons. Remodeling the stomach, which is going to be kind of the basis for my talk today, looking at imbrication of the greater curve, plication, and suturing, and the rest of the talk you'll hear about that. I will not be dealing with the other modalities, including diversion of the caloric content away from the stomach. So you can see that we have, of course, a spire, which is the PEG tube used to aspirate calories once they're ingested, and we have special stents to improve satiety, and the transpyloric shunt. So really, there's a big range of therapies. All of these are almost investigative, early stage development, and the sleeve gastroplasty, I think, is the one which is perhaps the most mature from the endoscopic investigative point of view. Now, I remember Roberta Fogel in Caracas, Venezuela, back in about 10, 12 years ago, and I was there giving a lecture, and he was telling me about his gastroplasty that he was using doing with the Endocinch device, which was a barred device which really didn't have transmural suturing, it was more mucosal suturing. And he was presenting some very good results. And I also remember that most people looked very skeptically at the whole approach endoscopically, thinking that there was no role for endoscopic suturing for obesity. And when he showed sort of his one-year results, looking at the excess weight loss after 1 year, it was in the range of 40 to 50% of excess weight loss with his suturing technique at 1 year. And so this was really the first serious attempt to evaluate remodeling the stomach, if you like, with suturing in a fairly large cohort of 64 patients followed up for 1 year. So it set the stage for further development. One of the other sort of areas of suturing that came along was what we call primary obesity surgery endoluminal. I mean, all of these things have to have a good acronym. I thought that this acronym was lousy because, you know, coming up with an acronym of POSE was very difficult. But essentially, this was taking a suturing device made by USGI Medical and creating plications in the fundus of the stomach, 8 to 10 plications, and then 3 to 4 plications in the antrum of the stomach. And again, the early results of this approach were about 50% excess body fat weight loss at 1 year. And what was different about this particular device was that it uses a type of suture retention. Let's see if I can, I don't have a pointer here, do I? No. Anyway, it's a large, what they called snowshoe retention device to ensure that the sutures were maintained and did not get dislodged. Now, I'm not going to spend a lot of time on this device, but I will say that perhaps the best prospective study that has been done looking at endoscopic suturing was with this particular approach. It's called the Essential Trial, reported about a year and a half ago. Shelby Sullivan was the principal investigator. What made this trial particularly good was that they assessed 587 patients. They randomized 332 patients into a 2-to-1 ratio of the active treatment versus sham, and their follow-up at 12 months was excellent. So we had 213 of 221 patients treated, available to follow up in the active arm, and 106, 111 in the sham arm. So you couldn't ask for a better designed trial to evaluate this modality. They made one small error, which you'll see here, is that when they looked at the outcomes, we can see that the percent total body weight loss at 12 months in the active group was only 5%. The sham group, 1.4%. Yes, significantly different, but far less than what any of us would expect or anticipate with this kind of intervention. And what they did, what was described as the responder rate, which was established by the American Society of Obesity, was that you would lose at least 5% of your total body weight. This was only achieved in 42% of the active arm and 22% of the sham. So why are the results of this trial so bad compared to every other review in the literature? Well, number one, it's prospective, so it's well controlled. But what they designed intentionally was to have almost no lifestyle modification associated with the endoscopic intervention. And of course, I'm sure you've heard from our surgical colleagues or anybody who deals with obesity, you have to have a multidisciplinary approach. You cannot lose weight in any sustained basis with a single intervention. So I think that was the big failing of this particular trial. And if we look at Lopez-Nava's review of predictors of success with 1 year follow-up, and these were patients who had sleeve gastroplasty. They didn't have the pose procedure. But if we look at the relationship between follow-up and results, so if you look at the panel on the left, you can see low adherence on the left, and to the right is high adherence to the follow-up, and we can see the difference in the outcomes with the patients who adhere to the follow-up, both with psychological and nutritional follow-up following their gastroplasty. So there's no question that this emphasizes that whatever I say about sleeve gastroplasty as a standalone procedure will not work unless it's coupled with nutritional and psychological counseling. So I've been asked to talk about sleeve gastroplasty. This really became possible with the development by the Apollo group of the endoscopic suturing device, the overstitch device, which you can see here. This is the traditional device for a 2-channel scope. The newer device can be used with a 1-channel scope, which I have no experience with yet. It's just been released in the last few months. But you can see the features of this device are that it has a needle which is curved that moves in and out. It has a helical retractor, a tissue retractor to pull the tissue in. And then it has a way of cinching the suture once it's been placed through the tissue. I'm going to show you how this works. The design of suturing with endoscopic gastroplasty is to imbricate. It's really to mimic sleeve gastrectomy. So what we're trying to do is to take the anterior greater curve and posterior wall of the stomach, and we're pulling it in with the sutures in order to reduce the capacity of the stomach. Initially, when this was done by Roberto Fogel back in the 10, 12 years ago, they started proximally and went distally. Now this has evolved where the procedure starts at the antrum and moves proximally up to within 1 centimeter of the gastroesophageal junction. So you can see there are different patterns of suturing. Each suture is used for 6 to 9 sort of grabs of the tissue, if you like. At the top is the most popular design, where we take anterior wall number 1, greater curve number 2, posterior wall number 3, and then we move across and repeat that, and that's one suture, and then we cinch up that particular suture, and we continue with about 6 sutures up through the stomach. Initially, fundic reduction was a big part of it because of a lack of evidence that it enhanced the outcomes, and because of the increased risk of putting sutures through the fundus. There's risks of splenic injury. It's a 2 millimeter wall thickness in the fundus, so the risk of bleeding was higher, and infection. So fundic reduction has really been dropped as a part of the procedure. Some people use a linear reinforcement, so after the initial row of sutures is completed, a second suturing is done to sort of reinforce the first line of sutures. The second pattern you see below is to ensure that all of the greater curve is pulled in and tightly bound. So although we start with 3 sutures lined up, we can go to 4 or 5, how many as are needed to ensure closure, imbrication of the greater curve. So this is, I've taken this video from our course. We run a course in New York, the New York Society of Gastrointestinal Endoscopy, and at NYU I do all the live demonstrations. We do about 20 cases, and one of the leaders in gastroplasty is Reem Sharaya, who's in New York City. You can see her up here on the right in the image, and this is her performing live this year. So we can see here the Apollo overstitch device, and this is the helical retractor, and this is meant to be screwed right into muscularis propria. Obviously that stitch did not go deep enough, so now we're going again with the helical retractor. So it's critical to pull enough of the tissue in that you get muscularis propria. You need to get the stitch or the suture into the muscularis propria in order to hold. So the stitch is driven through the tissue, it's picked up by the opposite side, and then it's reloaded onto the needle. The suture is reloaded onto the needle, and the second location for the stitch is chosen along the greater curve here. Same thing. You can see that there are marks in the stomach made by, there are thermal marks which indicate the anterior and posterior wall. And you can see here, once we have thrown 6 passages of the suture through the wall of the stomach, and here again, making sure we have full thickness, we can see that a tunnel is created here, which mimics sleeve gastroplasty. There are some obvious differences. I don't think we can get as small a tunnel as you can get with a sleeve gastrectomy. And there are some differences in the outcome. For instance, with sleeve gastrectomy, the passage through the stomach is much quicker, and with the gastroplasty, it's slower. So there are differences in the way this works. Now, the largest, before we go to that, just a few notes on procedural management, because this is probably the most important slide of the whole talk, because it emphasizes the need for careful management of the patient. So for 2 weeks prior to the procedure, the patient's on a PPI, liquid diet only the day before the procedure, and the patient receives a very strong antiemetic, which is given 3 hours before the procedure. One of the things we do not want to happen is to have the patient retching or vomiting, because every patient is nauseated, has some abdominal pain after the procedure, and if they have vigorous vomiting, they can actually dislodge sutures. So they get the aprepitant beforehand, and then during the procedure, we often give solumedrol. Then afterwards, they're on antiemetics, they get Zofran, on Dancitron, and Emend after the procedure for at least 2 weeks, and they're on a PPI for 6 weeks. And an antibiotic is always given during the procedure, but there have been a couple of case reports of infection and perigastric fluid collections. So there's a trend now to include antibiotics for 3 days after the procedure. The diet's very important, so the patient really is on liquid diet only for the first 3 days afterwards, pureed foods after that, and soft foods for up to a month. So this is very important in terms of allowing the healing of the stomach, not stretching the stomach, and hopefully to allow for fibrosis to occur where the sutures have been placed. The bottom right, this is the active follow-up of the patient. If you don't do this, you don't lose the weight. You just don't. So most of the studies that you can read in the literature, they're not that many, to be honest with you. Almost everyone includes at least a monthly visit, and in the first 2 months, really contact with one of the management teams at least weekly for about 6 weeks. This becomes very, very important in terms of compliance of the patient. This multi-center study was headed up by Lopez Nava, looked at the results at 24 months, so the longest follow-up in the largest cohort of patients. So 248 patients from 3 centers, from Madrid, the Mayo Clinic in Rochester, where Abu Dhabi is working, and finally from Cornell in New York City. So we can see here, if you look at, first of all, the bottom panel. Sorry, is there a pointer here? No, I guess not. Anyway, you can see here the bottom panel with all of the centers included. The total body weight loss at 24 months was 15%. So very respectable weight loss at 15% at 2 years follow-up. And we can see, at 6 months and then at 2 years, 18.6% when you take all of these centers together. So on a per protocol basis, we have at least 84% of the patients achieving more than 10% total body weight loss. Excellent results. If we look at the results related to the initial BMI. If the initial BMI is lower, less than 35, we can see that the weight loss is somewhat less at 13.6%. Obviously, the larger the patient is, the greater the weight loss, and we have a 21% weight loss in the larger group. So I think if we look at the treatment combined with the multidisciplinary approach, which all of these centers have and emphasize, we can see that you can look for a minimum of a 15% total body weight loss at 2 years. Complications, and I think this is a big plus with gastroplasty. So we have 248 patients followed quite closely. Only really 5 serious complications out of 248 patients. Very low complication rate. 2 perigastric fluid collections resolved with percutaneous drainage and antibiotics. 1 extragastric hemorrhage from the needle driver going into a vessel. Blood transfusion, but no other intervention. 1 pulmonary embolism, and 1 pneumoperitoneum and pneumothorax requiring chest tube, which occurred more often when the fundus was being reduced with suturing. If you did any kind of scanning, CT scanning, because these are transmural sutures, you will have carbon dioxide. You will see capnoperitoneum in a small number of cases, which brings me around to the point that you cannot do this without carbon dioxide when you're doing a full thickness needle driver through the tissue. So you have reasonable success and minimal complication. Now, last year, a European group, which included a group from Czechoslovakia, Costamagna's group in Rome, and Devier's group in Brussels, they reported on the Endomina device, which we do not have in the United States, but it's I think, the answer to the overstitch. And it's, again, creating plications, double plications, with 6 to 8 plications along the greater curve. Some that have been added to the antrum. So the preliminary results with this device are somewhat similar, perhaps not quite as good. The total body weight loss with 45 patients at one year was 7%, so 7 to 8%. So the results not quite as good as with the Apollo overstitch device. There have been some comparative studies trying to look at results of the endoscopic versus surgical approach. And we can see here in this study reported last year that if we look at the graph at the top, the percent total body weight loss is much, much better with the sleeve gastrectomy compared to the endoscopic gastroplasty or the band, which are very similar, and not about half the weight loss. So on average, the weight loss was about 17% with the endoscopic approaches, 24% with sleeve gastrectomy. The biggest difference were in the outcomes related to readmission, hospital length of stay, etc. So if you look at length of stay, obviously with the sleeve gastrectomy, 3 days, 0.3 days with endoscopic gastroplasty, and band in between. Readmission at 90 days, 4% versus 2%. Total morbidity, 9% versus 2%. Events that required surgery or endoscopy, 4% versus 0%. So the big difference is the complication rate, but I have to say that the patients who undergo surgery are generally have more comorbidities, because for a lot of the insurance companies, the ability to get the surgery paid for is the presence of comorbidities. So you're selecting out patients who are at higher risk to begin with. So I think we have to add that caveat to interpreting these results. This was a somewhat better comparison, and this is from the Johns Hopkins group. So what they did was they matched the patients who had the endoscopic gastroplasty with those who underwent sleeve gastrectomy. So you can see that they matched them for age. So the gastroplasty group, age 48, gastrectomy, 47 age, and the median BMI 43 and 44. So these patients were matched for age and BMI, and but if you look below that, this was sort of a, the catchphrase is retrospective analysis of prospectively gathered data. And if we look at this, we can see that the surgical group, the comorbidities are much higher compared to the endoscopic group. So these are a more difficult population of patients. If we look at the outcome from Johns Hopkins, we can see that if you look at the trend in terms of the total body weight loss, the higher yellow color indicates the surgical results, which are basically about 24% total body weight loss. And the endoscopic results prospectively followed with gastroplasty, really in the order of about 15% roughly. So there's no question that sleeve gastrectomy achieves a better result and probably better long-term result. That's one of the pitfalls of analyzing all this data is we have only maximum 2-year follow-up on large cohorts of patients. But there is a difference. We've talked about complications of the surgery and lower adverse events with endoscopic approaches. But GERD has become also a big issue following sleeve gastrectomy. So we see new onset GERD in this population looked at prospectively was 14.5%, 15% in the group who underwent surgery. So GERD may be a problem. Our group at NYU did a review of patients who underwent bariatric surgery and found that new onset of Barrett's esophagus was found in 15% of our population. So management of GERD and GERD is an issue with the bariatric procedures. So in conclusion, I think it's based on very early data, very few randomized controlled trials. No question we're looking at a modern day epidemic. Current surgical approaches only deal with the tip of the iceberg, the 1 to 2% of patients who are achieving surgery. And I say that endoscopic approaches are ideal in terms of would be the best approach for these patients, an outpatient procedure, minimal complications, and high efficacy. Those would be what we're looking for, but we don't yet have the ideal solution. But I think with the gastroplasty, we're starting to move in the direction of finding an answer to the problem. Thanks very much.